Hello, my name is Heather Rolph Ibberson, and I am a student nurse practitioner at Pacific College. Today, I'm going to present a patient case video presentation on type 2 diabetes mellitus. Epidemiology of type 2 diabetes mellitus. Incidence. Diagnosed cases account for 21 million, with an estimated 8.1 million who have not been diagnosed. The incidence of type 2 diabetes has been rising in the children and adolescent populations, and it's associated with the growing incidence of childhood obesity. Prevalence. It is estimated that 29.1 million Americans have diabetes, which equates to 9.3% of the population. 90 to 95% are likely type 2. According to the Centers for Disease Control and Prevention's National Diabetes Statistic Report, in 2019, 37.3 million Americans, or 11.3% of the population, had diabetes. Nearly 1.9 million Americans have type 1 diabetes, including about 244,000 children and adolescents. Of the 37.3 million adults with diabetes, 28.7 million were diagnosed and 8.5 million were undiagnosed. The percentage of Americans aged 65 and older remains high at 29.2%, or 15.9 million seniors. 1.4 million Americans are diagnosed with diabetes every year. In 2019, 96 million Americans age 18 and older had prediabetes. About 283,000 Americans under age 20 are estimated to have diagnosed diabetes, approximately 35% of that population. In 2014 and 2015, the annual incidence of diagnosed diabetes in youth was estimated at 18,200, with type 1 diabetes, 5,800 with type 2 diabetes. Etiology of type 2 diabetes, genetically and clinically a heterogeneous disorder with familial pattern, influenced by environmental factors, lack of physical activity, diet high in refined carbohydrate and fat with low fiber, obesity, no human leukocyte antigen or islet cell antibodies. Syndrome of hyperinsulinemia and insulin resistance, resulting in hyperglycemia, hypertension, and hyperlipidemia to varying degrees in all patients. Drug or chemical induced, drugs used to treat psychosis, HIV, or transplant recipients. History of present illness. 65-year-old obese Caucasian male presents to the clinic for glycemic and hypertensive control and to discuss adding Trulicity to his regimen, stating it will target both my glucose and hypertension. Patient brought 3 articles on Trulicity he printed from home. He reports previous hypertension treatment with lisinopril 3 years ago and states, I experienced adverse side effects such as fatigue, nausea, and upset stomach. He reports that he used to take metformin, stating, I stopped taking it after reading bad stuff about it. The patient states, I would really like to be on as little medication as possible. He then states, since Trulicity will target both my glucose and high blood pressure, perhaps I won't need blood pressure medicine. He reports he has not taken the lisinopril since it was prescribed, as he did not want to deal with the adverse side effects. Recent lab results and past medical history is significant for type 2 diabetes mellitus, hypertensive heart, and renal disease. Patient had labs completed on February 4th, 2022 with elevated glucose, bun creatinine ratio, and potassium. His eGFR was 47. Patient self-reported a blood glucose reading of 159 on March 7th, 2022, and reports that he took 20 units of Lantus. His prescribed Lantus dose is 27 units, injected subcutaneously once daily at night, but he states, I make my own sliding scale based on past blood glucose readings I have charted in my phone. He then states, I do not want to take too much insulin and cause my blood sugar to drop too low, so I base my Lantus dose on what dose has worked in the past based on my blood glucose reading. Today his blood glucose level in office was 123. He is adamant about starting on Trulicity today. He reports he is unable to take his blood pressure at home due to a malfunctioning blood pressure cuff, which he brought today. Past medical history. Amputation of the right foot. Onset 2017. Cataracts. Onset 2020. Immunizations. COVID vaccine. Pfizer. First dose on March 9, 2021. Second dose on March 31st, 2021. Booster on September 10, 2021. He had a Tdap booster on November 2021. He reports no recent influenza vaccine pneumococcal conjugate vaccine, PCV13, hepatitis B vaccine, or zoster vaccine. Past surgical history, laser cataract surgery in April of 2020. Current medications, Lantus, 100 units, 3 milliliter pre-filled pens. Allergies, no known drug allergies. Family history, mother had heart failure and sleep apnea and died at age 69. Patient reports no information on paternal father. Social history, he is a mechanical engineer, divorced, and lives alone in an apartment. He has 2 adult children, a 29-year-old daughter and a 26-year-old son, whom he regularly sees because they live nearby. He is a non-smoker who has never used e-cigarettes, vape, or smokeless tobacco. He smokes indica marijuana for pain management. He drinks a moderate level of alcohol, consuming 5 alcoholic drinks per week, either beer or wine. He consumes a moderate amount of caffeine, 2 cups a day, follows a low-carbohydrate diabetic diet. Review of systems, constitutional. No significant weight gain or loss, no fever, chills, malaise, night sweats, or exercise intolerance. Eyes, he reports a history of floaters bilaterally in the eyes, stating that he saw a retinal specialist in Arizona and had surgery. Patient denies regular diabetic eye examinations, stating that he has not seen an ophthalmologist in over a year. He reports hyperopia, which is farsightedness, and wears readers at home. Ear, nose, mouth, and throat. He reports recurrent childhood otitis media and intermittent tinnitus. Cardiovascular, no shortness of breath when walking or lying down, and no palpitations, chest pain, arm pain on exertion. No known heart murmurs or ankle swelling. Respiratory, no cough, wheezing, shortness of breath, coughing up blood, or sleep apnea. Gastrointestinal, no constipation, diarrhea, nausea, vomiting, dyspepsia, GERD, or abdominal pain, and normal appetite, not vomiting. Genitourinary, no incontinence, hematuria, difficulty urinating. Patient denied incomplete emptying of bladder or changes in urinary or bowel habits. He denies prior colorectal screening and reports he has never had a prostate exam. Musculoskeletal, difficulty walking related to history of transmetatarsal amputation of his right foot. He reports use of a carbon fiber shoe filler but states that it doesn't help. Neurologic, no weakness, numbness, seizures, dizziness, migraines, headaches, tremors, paralysis, or loss of consciousness. He reports gait dysfunction. Psychiatric, no depression, anxiety, hallucinations, agitation, dementia, delirium, sleep disturbances, suicidal thoughts, mood swings, or memory loss. Endocrine, no fatigue. Hematologic and lymphatic, no bruising or swollen glands. Vital signs, 170/86, pulse 79, respirations 20, temp 98.7, oxygen saturation 97% on room air, pain 0 out of 10, older obese male who appears well developed, well groomed, and cheerful. He is awake, alert, and responsive and does not appear to be in any acute distress. His height is 6 feet 2 inches, weight 240 pounds, BMI 30.8. He can ambulate on his residual right limb but appears to do so with a limping, shuffling gait pattern. He is in an upright posture and keeps his eyes at level. His eyelids and conjunctivi, no discharge or pallor, and non-injected. Pupils are equal, round, and reactive to light accommodation. Corneas are grossly intact. EOMI. Lens is clear. Sclera non-isometric. Vision, peripheral vision grossly intact, and acuity grossly intact. Neck supple from trachea, midline, and no masses. Lymph nodes, no cervical LAD, supraclavicular LAD, axillary LAD, or inguinal LAD. Thyroid, no enlargement or nodules, and non-tender. Apical pulse, not displaced. Normal S1, S2, no murmurs, rubs, or gallops, and regular rate and rhythm. Neck vessels, no carotid bruits. Pulses including femoral and pedal, normal throughout. Bowel sounds, normal in all 4 quadrants. No tenderness, guarding masses, rebound tenderness, or CVA tenderness, and soft and distended. Liver non-tender and no hepatomegaly. Spleen non-tender and no splenomegaly. Muscular skeletal. Limited range of motion, transmetatarsal amputation of right foot. Neurologic, shuffling gait in the right residual limb, lower extremity. Cranial nerves 7 through 12 are grossly intact. Monofilament test intact. Reflexes 2+ bilaterally throughout. skin, no rashes, lesions, ulcers, no abnormal nevi, no induration, no nodules, good turgor, no jaundice, and his nails are normal. Differential diagnosis, metabolic syndrome, medication non-adherence, and hyperlipidemia. Diagnosis, type 2 diabetes mellitus with unspecified complications. Patient's BMI, when calculated, is classified as category 1 obesity. For his height, a healthy weight range would be 144 to 194 pounds. Patient was started on Trulicity, 0.75 milligrams of Trulicity via subcutaneous injection once weekly, and informed that it can be taken at any time of the day and with or without food. Informed patient that if a dose is missed, administer the missed dose as soon as possible if there are at least 3 days or 72 hours until the next scheduled dose. Instructed patient to inject Trulicity subcutaneously in the abdomen, thigh, or upper arm. Discuss proper disposal of used pins with patient, instructing him not to throw away or dispose of pins in his household trash. Educated patient on storage and handling, including instructing him to store his Trulicity pin in the refrigerator between 36 degrees Fahrenheit and 46 degrees Fahrenheit, or at room temperature below 86 degrees Fahrenheit for a total of 14 days. Patient was given a printout of side effects associated with Trulicity, including nausea, diarrhea, vomiting, abdominal pain, decreased appetite, indigestion, and fatigue, and when to seek emergency medical care. Patient instructed to discontinue use of Lantus, informed him that the use of Trulicity and Lantus together is known to cause hypoglycemia in males. Patient's Lantus was discontinued from his medication list. Discuss signs and symptoms of hypoglycemia with patient. Patient will increase his physical activity as tolerated to 150 minutes per week of moderate intensity to 300 minutes a week of moderate intensity, or 75 minutes to 150 minutes a week of vigorous intensity aerobic physical activity. Lipid panel standard needs to be ordered for patient to assess possible hyperlipidemia. Patient will schedule a follow-up appointment to assess glycemic control, medication effectiveness, and for future refills in 3 weeks. Patient educated on foot care, including to avoid going barefoot, testing water temperature before stepping into a bath, trimming toenails to the shape of the toe, removing sharp edges, not cutting cuticles, wash and check feet daily, shoes should be snug but not tight, and socks should be fit and be changed daily. Patient is waiting for Medicare approval. Once approved, he should be referred to an ophthalmologist or optometrist for dilated and comprehensive eye exam annually. Patient has a history of prior amputation and should be referred to podiatrist. Due to patient's labs and complications in the management of his hypertension and hyperkalemia, consider referring the patient to a physician experienced in the care of diabetic renal disease. Patient educated on the most common causes of CKD, including diabetes and hypertension. Patient educated that the early stages of CKD, there are no symptoms. However, the disease can progress to complete kidney failure, also known as end-stage kidney disease, requiring dialysis or kidney transplant to maintain good health and even life, which is usually when kidney function is approximately 10% or less of the normal kidney function. Inform the patient that the main goal of treatment is to prevent progression of CKD to complete kidney failure, including early diagnosis and control of underlying causes. Patient given a quick overview of normal kidney functioning. Educated the patient on how the kidneys control the amount of sodium, potassium, phosphorus, calcium, and other chemicals in the body, and in order for this filtering process to occur properly, the blood pressure and blood flow to the kidneys need to be adequate. If the imbalance occurs, many critical bodily functions can be affected, possibly producing symptoms associated with kidney disease. Essential primary hypertension. Patient reports not taking his prescribed lisinopril due to adverse effects. Lisinopril was discontinued from his medication list. Patient's blood pressure taken twice in office today. First reading was 198/91. Left arm sitting. Second was 170/86. Right arm sitting. Patient denies palpitation, shortness of breath, dyspnea or a headache. Discussed initiating chlorothiazidone a diuretic to treat his hypertension, and informed patient that lowering high blood pressure helps prevent strokes, heart attacks, and kidney problems. Discussed how chlorothalidone is also used to reduce excess sodium and water in the body caused by conditions such as heart failure, liver disease, and kidney disease, including how this decrease in the body helps decrease edema, breathing problems caused by fluid in the lungs. Patient started on chlorothalidone 25 milligram tablet and is instructed to cut the tablet in half and take 0.5 tablets once a day in the morning. Total daily dose of 12.5 milligrams. He was given a pill cutter to take home. Discussed most frequently expected adverse side effects associated with chlorothalidone use, such as hypotension, dizziness, renal dysfunction, and electrolyte abnormalities. Patient will have his serum electrolytes monitored periodically. Inform the patient that it may increase the amount of urine he makes, particularly when first started, and how it helps to relax the blood vessels so the blood flow can flow more easily. Inform the patient that chlorothalidone can help lower his potassium. We'll reassess patient's potassium in 3 months, which is June of 2022. Patient presented with a defective blood pressure cuff and was given a brand new blood pressure cuff to take home and instructed to assess his blood pressure twice a day, once in the AM and once in the PM. Patient was given a printed home blood pressure log and instructed to keep recording daily and bring to his follow-up visit. Patient instructed to schedule a follow-up appointment in 3 weeks to evaluate medication effectiveness, adherence, review his blood pressure home log, recheck blood pressure, and refill medication. Patient educated on diet modification and potential side effects associated with elevated potassium. Abdominal assessment, negative for ascites, bladder distension, tenderness, and pain. A renal ultrasound was ordered for the patient to rule out hydronephrosis. Patient was given a printed community health slip for renal ultrasound, informed patient that his ultrasound results will be discussed at his follow-up appointment. Thank you.